to sleep before lunch and waking up afterwards. So this is the sending you to sleep bit. So can I just ask you first, I'd just like to know the audience, hands up consultants, quickly, consultants. Cool, lots of those. Senior trainees, 6, 7. Okay. Junior trainees, not a pejorative term. Yeah. Any midwives? Oh, lots of midwives. Oh, you've got satellite. Hi. Great. Okay. Delivery. Okay, so that is the only funny slide that you're allowed to titter at. The rest are all highly serious. You're going to get copies of them. As always, I've got hundreds of slides, but lots of pictures, so you're welcome to all of them, and lots of pictures, so that's quite good. So what I want us to do is 2 halves to the talk. The first half is about how we should deliver twins in terms of mode of delivery, and then the other half is about how we might deal pragmatically with vaginal twin delivery. And quite a lot of that, I think, is pragmatic and anecdotal, because I think that's how most of us learn how to deliver twins and their complications. So one of the things is to think about for this is how much risk with twin delivery is actually due. Where does the harm occur? And what you have to remember is that twins are a high-risk pregnancy. They're a high risk all the way through, and some twins are higher risk than others. So we know the monochorionic twins need closer watching than the dichorionic twins. So this slide just reminds us that there's morbidity through the antenatal period, although for monochorionic twins, interestingly, it seems to plateau somewhat once you get into mid-trimester. You're going to get all these slides. You're welcome to take pictures of them, or me, whatever you're taking pictures of, but whatever tickles your fancy. So, timing of delivery, we're going to talk about method of delivery, conducting twin delivery, and some specific complications. And there are 2 or 3 slides where I'm going to pause, give you a title, and say, what would you do? And hopefully you'll tell me. So, timing of delivery. Monochorionic twins generally in the 36th week with prior steroids, dichorionic twins in the 37th week, and triplets sometimes a little bit earlier. So, question about monochorionic twins that I always ask. How many people routinely in this room do or work in units that routinely section monochorionic twins? Good, it's getting less and less each year. So that's 2 or 3 hands in this room. Okay. So the evidence wouldn't support routine delivery of monochorionic twins by caesarean section. Okay, so why do we deliver early? I'm going to show you several variants on similar data. This is somewhat older data from Australia that shows the dramatic rise that seems to happen with twins at around 38 weeks. And if you want more recent data, and this is nearly 500,000 deliveries, you can see again, what I've marked for you there is 37 weeks, and what happens with twins with expectant management beyond that stage. And shown in tabular form, again you can see this quite distinct rise around here. Okay. So what about the, there's nothing better than just starting with the rare, and I saw my first set of monochorionic, monoamniotic twins we've dealt with in the last 6 months, and I've been doing obstetrics since, sadly, 1983. So it isn't that common, but she was managed, and how would you manage her antenatally? It's very interesting how you manage these people. What's the main risk for them antenatally? Cord entanglement. Okay, so is anyone here from the RVI in Newcastle? That's good. Okay, so they're my colleagues. Steve Robson and my colleagues. So they're normally managed in the Centre of Excellence, which is 13 miles from where we are. And, got the usual patient that said, well, what are you going to do for me in this Centre of Excellence? We are going to admit you from 26 weeks and you're going to stay in hospital till you have the babies, and you're going to have twice daily CTGs. And she said, well, what are you doing in between the CTGs? Not a lot. So why can't I have a CTG in the morning and come home and have a come back and have a CTG in the afternoon? And they said, I accept, she said, if you're not continuously monitoring me and the baby's going to tangle and acutely die, that's going to happen. And that caused a fair amount of angst. But then she said, even worse than that, she said, it's worse than that, Professor Robson. I want to go back to Sunderland and have CTGs twice a day, which is what she did. And interestingly, we were aiming for 34 weeks, and at 32 weeks she came in and had a CTG that showed signs of cord entanglement, decelerations and that sort of thing. So we actually didn't deliver acutely then, but we gave her some steroids for over 24 hours and delivered her the next day, and kept an eye on the CTGs. So I think, the trend has been to move from 32 up to about 34 weeks for these rare twins, and they get delivered generally by caesarean section, as you know, as do all triplets now. And I'm old enough to say that when I started, I used to watch triplets delivered vaginally, but that just essentially never happens now. Okay. So, mode of delivery. Look at this Canadian survey, looking at practice prior to 2003. And you can look at the relevant section rates for, here's the commonest combination, with a 6% elective caesarean section rate. And you can see that as twins were second twin, particularly here, with different types of breach, that section rate was higher, with much higher rates with twin 1, as is still the case now, with twin 1 being breach. And then we get into the why should we section all twins versus should we not section all twins. And this is data from Gordon Smith 12 years ago. And this, obviously, would have you sectioning everybody, because no babies die of intrapartum anoxia. But it is retrospective data, and you can guess I'm going to show you data from the twin birth trial. So that was retrospective data in 2005, and then here's other data, however, from 2011, a big twin set, 40,000 retrospective, showing that actually overall neonatal mortality was lower for vaginal delivery versus elective section. So, like anything in life, you can choose the data that you want to choose to support the argument you wish to make. And I guess, as with many things that happen in obstetrics, the more sections we do, the more we potentially de-skill. Because for twin delivery, you may well need to be skilled in vaginal breech delivery. And the problem is, it's a bit of a vicious circle, because we don't deliver singleton breeches in this country anyway, vaginally, whereas I go and teach in Bergen, and it's routine to deliver them vaginally still. So we don't develop those skills. So, and again, you've heard about the risks of caesarean very nicely from Sarah just now. So let's look at the twin birth study in just a few slides. Randomised trial led by John Barrett and his team in Canada, and it came up for some criticism because it was looking at delivery of twins at 32 to 38 weeks. And one of the criticisms of the paper was there was a relative dearth of deliveries between 37 to 38 weeks, which is obviously the sort of time we're inducing those patients that get through to term with dichorionic twins. So, randomised trial where twin A is presenting cephalically, and secondary outcomes looking at risk of death, poor neurodevelopmental outcome at 2 years, and I can show you that data in a minute. And with all these trials, and there are some very big trials, as you know, have come out, and the woman trial being the biggest that I've seen most recently, this was the background to it. 106 units, 25 countries, standard sort of antenatal care, continuous CTG during labour, facilities for section within 30 minutes, and attended by qualified obstetrician, inverted commas, experienced at twin birth. So here's another question for you. Midwives first. Hands up for all your midwives so I can get an idea of how many there are. How many of you have delivered more than 5 sets of twins? A few? That's quite a few. Okay. How many of you did more than 10? No. So failure numbers. Now, for the trainees, who's delivered, or been responsible for delivery, including if midwives are doing them, so you're there as an obstetrician, delivered more than 5 sets of twins? 10? 15? Okay, 10 to 15 maybe. Okay. And for consultants in the room, how many think they've delivered 50 sets of twins? I don't even know if I have, to be honest. I don't even know if I have. Because I've not kept a record, but I would doubt. It's really quite difficult to know. But, you know, it's interesting how experienced people may or may not be. So anyway, our claim to fame in Sunderland is that we recruited the penultimate patient in the term breach trial. And we got a little flag, so we just got the trial over the line. Well done. Okay. You don't need to update. The demography shows very good randomisation between planned section and planned vaginal birth. And of course it was analysed on intention to treat, and this is a vitally important slide, of course, because obviously in the caesarean section group it was about 90% actually had a section. If they did deliver vaginally, they're still analysed within the intention to treat, and that's how you run RCTs. But it's quite interesting that if you look within the planned vaginal birth route, almost 40% were delivered by caesarean section as well. Okay, composite neonatal outcomes were no different. You can see the odds ratio is 1.16 with the confidence intervals crossing 0. So no overt advantage to the baby. And that's why maybe, if you think to the slide before, we're not really, are we, able to say that elective caesarean section is better or worse than achieving a vaginal delivery. What we've compared is a planned elective section and a planned vaginal delivery with judicious use of caesarean at 40% makes no difference to perinatal outcome. And that's quite a planned vaginal birth with judicious use of emergency section is as safe as having an elective section. Quite an important difference. Okay, what else? Other neonatal outcomes are the same. And if you come to maternal outcomes here, only one maternal death, very fortunately, in each arm, but a composite of serious maternal morbidity, no different. And that might not be a surprise, because 40% of caesareans were emergency in the vaginal birth arm. And the maternal outcomes, otherwise, no different. So I'm not going to dwell on those. You can look at the detail when you get them. So the summary for the trial is quite important. No differences in the risk of fetal plus or minus neonatal death or morbidity. No reduction in risk of adverse outcome for the second twin. Equal risk of maternal mortality and morbidity, but reflecting this very important point, a 40% emergency section rate, limited numbers to the time when we aim to deliver a lot of our twins, and this always concern about these large trials, transferability to specific countries. Longer-term follow-up. Well, I can give you some longer-term follow-up. This is the 2-year follow-up published last year. Policy of planned section, no benefit to children at 2 years of age compared with a policy of planned vaginal delivery in uncomplicated twin pregnancy. Okay. And then a really quite important paper. Putting around with too many things. This one, that's just literally been published, exploring women's preferences for mode of delivery. And this I'm going to let you read, because it's really quite an important conclusion. What it essentially says is that they, and did you see that they followed, this was at 3 months post-delivery, 92% of that study population followed up. And what it clearly says is whether women had a vaginal delivery or section, there's an absolute clear preference for having the option of going for vaginal delivery. That's quite, and should be quite, an important influencing factor for us as obstetricians and as maternity care providers. So the question I leave you is, has it changed practice? Because those people who did elective caesarean sections for all twins will argue it's as safe and no different for mums and babies to have that as it is to have a policy of planned vaginal delivery. So we were a planned vaginal delivery bailout if you need to unit, and we still are. So and I think that's sometimes what data shows. It says that you can still keep doing what you were doing before. So just out of interest in this room, how many units go routinely for planned vaginal delivery for uncomplicated twins? And how many go for planned, sorry, did I say vaginal delivery? Planned caesarean section for all twins? Okay, well, that's quite interesting. No, I'm just saying that, no, not incorporating maternal choice, because maternal choice is a huge influencer in everything we do now, isn't it? I mean, I have to say that even in Sunderland, we now have had the first two or three women asking for elective section primate cephalic singleton pregnancy. And I know in other places around the country that is much higher. I mean, I've been in Sunderland now since 1994, and we've had our first two or three this year. All right? Now, I know that's very different in other places. Okay, so we're on good time here. Conducting twin delivery. And there are a couple of references there that you can easily look up if you want to not believe what I tell you and believe someone else. So some of this is certainly my opinion, but I am going to ask you some questions. Staffing. I put in boxes the important things. What is an experienced obstetrician? Now, I've asked you how many you've delivered. Now, even as a trainee, you might well get signed off as competent to do. You've had your 3 ticks in the box. But actually, you know, I always ask this question to every audience. If your wife or partner was having twins, would you want the ST3 who's got 3 ticks in the box, so they're competent to do it on their own, or would you like the consultant to be somewhere nearby? If the answer is the latter, then you need 24-hour consultant presence on the labour ward, and we could spend all day talking about it, couldn't we? But we've got to ask, what is experience enough? And experience to me, as I will come to show you, is able to do an ECV, able to scan twins, which I can tell you, I spend most of my daytime scanning, is not easy in labour. I've seen twins with 3 heads, 4 heads, 8 legs, and got very frustrated with trying to scan in the middle of labour. So I don't think it's necessarily an easy skill. Able to do ECV and able to do internal pedalic version if you want to do vaginal breech delivery. And all the other things that just, you know, don't happen on adequate midwifery, ancillary and neonatal staff. Right, so well-staffed labour ward. And an anaesthetist skilled at epidural spinal who doesn't want to stay in bed when you say, the twins are fully, would you please come and be sitting somewhere, I'll make you a cup of tea if you get out of bed. Okay, 2 questions for you then. Should consultants be present for all vaginal twin deliveries? Now, you can't add to that, if it was mine, yes. All right? This is a real question. Who thinks a consultant, not conducting, should be in the labour ward, sitting at the desk for every twin delivery? All right, listen, I'm 58. I don't want to be in at 3 o'clock in the morning, I can tell you, and I've got my hand up. Okay. Right, should the anaesthetist be present on the labour ward outside the room for all twin deliveries? There's no anaesthetist in here, so we're not going to... Oh, there's one. Oh, sorry. Have you got your hand up? Where's the anaesthetist? Oh, you've got your hand up. She's got 2 hands up. That's even better. Fantastic. Great. Okay. So I love this. I've done quite a bit of work on college committees, so I do like this statement. Immediately available. I am immediately available. I'm in Harley Street. I'm immediately available if you would like me to come to labour 10 miles away. So let's see. Right. We should be immediately... What is immediately available? Doesn't that mean on the labour ward? 4. Vagina breech. Trial of instrumental delivery in theatre. Twin delivery. Caesarean section at full dilatation. Caesarean section a bit more greater than 40 in Sunderland. That is, I'm not joking, about 15 to 20% of the population. Transverse. So in fact, you might as well be there most of the time. Right? Okay. And gynecology as well. We have to do gynecology as well sometimes. So anyway, immediately available. I say no more. Environment. Good sized delivery room, good equipment, adequate lighting, blah, blah, blah. Question, hands up. Should all twins be delivered in an obstetric theatre setting? Who delivers their twins? Anyone do that? Routinely? 1, 2, 3. 2 or 3. Who would do it in a delivery room? I mean, assuming you've got, longitudinally lying twins. Fine, okay. You're going to be all fit. You've got your hands up so many times here. Okay. I'm only asking you these questions because I don't necessarily know the right answer. So some equipment, just to say, apart from things that you need, monitors, have an ultrasound scan around. I don't, what I do actually is have it plugged in the room before twin 1 delivers. Because when it spins around, you're going, plug it in, how do you turn it on? Oh my God, it's not starting. That doesn't help, all right? So, Boy Scout stuff, be prepared. IV access, I don't know whether you need 2, but you need some venous access. And I'd have if they haven't got Synto up, I'd have a Synto infusion run through, ready to go. All right, so there's pointless. This is all being be prepared and have resuscitators and be ready to deal with massive hemorrhage. All Boy Scout stuff. 2 midwives we would prefer, at least, I guess. And I'm going to come to monitoring in a second. And the unit been some occasional minor argy-bargy between the 2 cephalic twins. Why the hell do you guys need to be, or girls need to be around? We're the midwives, we can deliver them, we're fine. And let's be honest, it happens, the discussions occur. I'm very clear about what it is. If they're both cephalic, the midwife should deliver them. But the registrar I want in the room, because I want her generally now, 87% of the time, to do what important job? No, learning's important because you do normal deliveries. We never want to do normal deliveries. You're going to do those. We watch you do them very expertly. What's the most important job with a twin delivery? Stabilising twin 2. Stabilising twin 2. So I think it's reasonable that the reg should be in the room. Now, if you've got an experienced midwife who wants to stabilise, absolutely fine. But I can tell you if to keep us outside the room is not good, because I'll tell you why. If something goes wrong, we have to work out what's gone wrong having not been in the room. It is much easier to work out what's going wrong if you've been watching what's going on for the last 10 minutes. So let's work together and let's think about safety and not... We're a team. Teams should work together, and our prime aim is maternal and fetal safety. That's what we're there for. Okay. So, word of warning, this is true. Happened to us once. I lecture on human factors. Really important, this. We were monitoring these twins. Twin 1 had a pathological CTG, was pH 3 times, team changeover, pH. When they delivered, twin 1 was pristine and twin 2 was hypoxic. Situational awareness, level 1 error. No one realised or hadn't realised the monitors were the other way round. And when you have a type 1 error, what happens is you don't pick it up. No one picks it up. So just a word of warning. Just a word of warning. It's happened to us. So if it's happened to us, it can happen to you. Okay, I think that when people come in labour, the registrar should check the presentation clinically and with ultrasound. And then get as confused as I do sometimes. And you need to watch progress through the first stage of labour. And progress, on my next slide, will tell you that is at the same rate as singletons. Right? You should expect progress at the same sort of rate and manage it in a similar way. Second stage is to have a clear plan of management. And I think that's best done by, firstly, the team who are going to deliver, the midwives and the reg, sitting down together and saying, what are we going to do and who's going to be doing what and what do I need in the room? And that should be done during the first stage of labour, not when the first twin's delivering. Right? Work as a team. Act safely. Involve your anaesthetist. Don't ring them. The cord's fallen out on twin 1, it's transverse. Can you come? I'm brushing my teeth. All right? That's not much good. Okay? So we've discussed who delivers vertex at term. I think there's absolutely no reason it shouldn't be midwives at all. But I've discussed about why I think the Reg should be in the room with you, team. Someone needs to stabilise them. We've mentioned that as well. Who does it doesn't matter. As long as they're experienced, they know what they're doing. And then how long do you wait? How long do you wait? I'm going to give you 2 slides of data to suggest how long you wait. Because the contractions, it's like when you apply forceps to a baby, isn't it? You put them on and the contractions stop. Completely. And that's what happens with twins, I find. They stop. So you're going to wait. And of course, when you're waiting, a minute's a long time, isn't it? And 2 minutes, and 3 minutes, and 4, 5, 10 minutes. What are we going to do? What are we going to do? Can I rupture the membrane? But you do need the presenting part stabilised. So I generally wait about 10 minutes-ish. Okay, now, what data have I got to show you? Let's have a look. This is data showing fall in pH over time, which is equal for monochorionic and dichorionic twins. But can you see, I know it looks like dots all over the page, but the statistics show you there is a fall in pH over time. Okay? And if you look at the twin birth trial, the mean twin-twin interval is 8 minutes with a range of 1 to 33. So I would like the second twin out by 30 minutes max. And what's interesting is this, though. Look, 4% ended up with section. To me, vaginal delivery for the twin 1 and section for twin 2 is the ultimate disaster. Right? It really is. It's a real shame. And we'll talk about it in a second. But look, interval more than 15 minutes, the relative risk of section goes up 6-fold. Okay? So there is some data saying you don't just sit there for 3 hours waiting for twin 1 to come out. Okay? You have to be somewhat active. Okay, we're not too long now. Conducting twin delivery. Someone shout out, twin B, twin 1's delivered, twin B is non-vertex. So if it's breech, what are you going to do? Vaginal breech delivery. And if you've got that antenatally, you should have primed the woman beforehand, not now. So unless they're kef, she should be primed. What if it's transverse? Hands up for ECV. Hands up for ECV. I'm going to give you 2 options, ECV or IPV, internal cephalic version. So, hands up for ECV, external cephalic version, or external breech version, and hands up for internal pedalic version, which is put your hand in right. So you're about half and half. I'm going to show you some data, okay? Keep the membranes intact till you know what's happening, scan to find out, and get people around and about. If you're not experienced, don't rupture the membranes, wait, and get somebody in who knows it, right? ECV or internal version. Section should be in brackets, right at the bottom. Okay, internal cephalic version technique, put your hand in, find the foot, the ankle, and in the position the baby's at, go for the anterior leg, because as you pull on the anterior leg, just think about it, you'll keep the back anterior, right? That's the whole idea. Okay, so that's what internal pedalic, and make sure it is not a wrist, and make sure you can feel the heel. Okay, so you learn to do it. Well, John Barrett, look at this. IPV is an internal pedalic version, not necessarily breech extraction. What it is once it's stabilised, you can turn it into an assisted breech. But look at the outcomes here. In the UK, we tend to, I was certainly trained to do external cephalic version. But if you look here, look, significantly better to do an IPV with reduced section rate, reduced complication rate, significantly so, and reduced admission to neonatal unit, reduced RDS, reduced intraventricular hemorrhage. What does that say? IPV. That says we need to learn how to do IPV. That's what it says. Right, last few slides. Specific complications, a bit of time for you then. Unexpected ruptured membranes with twin 2. Twin 2, you're sitting there saying, great, everything's going good, I'm going to turn it around, really well. And suddenly, the membranes rupture, the baby's transverse. What are you going to do? Yes, IPV is number one, internal cephalic version. But actually what happens mostly, because consultants who can do IPV aren't there, rushing around to do a section and really not very good. So IPV, breech extract, needs to be done before significant uterine activity. So you might put tocolysis up, but I guess you have to accept if the skills are not immediately available, those famous words again, immediately available, you might have to go to section. Acute fetal compromise. Deliver twin 1, twin 2 sitting there, cephalic minus 40 up here somewhere. And the FH goes... Options? Hands up for IPV. Hands in, grab the foot. If the head's high, and you're an experienced, get your hand... That's what I would do. I go in and find a foot and pull it down. Other options? Vacuum and forceps. The problem is trying to put a vacuum on something that's bobbing away from you. But I know that when I've asked audiences for half-use vacuum, half-use forceps, you've got to work out what works for you. Got another idea? No, I thought you were... No. Maybe section. So there are lots of options, but I think, IPV, and you may need to go in quick. All right, so you've got to be prepared. Twin entrapment, locking, never seen it, right? We don't want to get twin entrapment, so ideally you pick it up antenatally. It's not that common. What do you do intrapartum, apart from poop your pants? This is it. It's very easy. You just sit there and you go, I've seen the slide. I'm going to pass my hand vaginally between the chins. I'm going to push twin 2 upwards, or I'm going to push twin 1 back and allow twin 2 to come forward, or I can do emergency section, or I'm just going to die. All right? So, but in all seriousness, you have to get your hand in there and disimpact by feel. It's going to happen to us once or never, I hope. Okay. Okay. Vertex. Most of us will deliver vaginally, but you do need expertise. For vertex, non-vertex, all of these, I think, are acceptable with twin 2 non-vertex. Vaginal delivery with assisted breech, vaginal delivery after ECV, vaginal delivery breech after ECV, or IPV. And although I put elective section there, I'd like to do that and say that shouldn't really be an option, bar maternal choice. And these are the indications for elective section, mostly around these rare twins, higher multiples. The thing about preterm twin 1 breech is up for debate. I don't think there's an easy answer to that. The evidence isn't there. Uncomplicated MC twins, that's the evidence from the RCOG green top, 36 to 37 weeks, unless there's an indication to deliver earlier. And that's the summary. I leave you with a question. Has the twin birth study really changed practice? It looks like it has, because most people seem to opt for vaginal delivery in this audience. There are still different options, and I think we should be teaching IPV skills, and you need to be skilled in these things. That I leave you as a final question, but the one real message I'd say to you is let's not sit in our little professional silos. Let's work as a labour ward team to offer the safest care for every twin delivery. Thank you.